very honored to have the chance to introduce our speaker, Dr. Lawrence Hanson. 我很高兴今天有这个机会跟大家介绍我们的讲师Hanson老师。He's the assistant professor of clinical psychiatry at Columbia University. 他是哥伦比亚大学的助理教授，他是精神科医师。If you go to the webpage of Columbia University, you'll see the admirable research and publication of these, including behavior economics and psychiatry, as well as application of the mathematic modeling in psychiatry, including game theory and decision theory. 它有很特别的发表，如果各位到哥伦比亚大学的网页去看的话，它是引进了数学模式在精神科的使用，而且它有一些文献是跟博弈还有决定策略理论在使用在精神科上面是非常特别的一位精神科医师。然后he also, as I know, he also worked with the instruction to the therapist who served for the clients with traumatic experience, including victims of terrorist attack, like 9/11. 同时我知道他也有在做一些指导治疗的工作，包括那些受创的，尤其是受到那个恐怖攻击的受害人，包括9/11事件的这样子。From today's speech, I'm sure he'll give us a very deep and broad view of the impact on childhood abuse and the impact from childhood abuse and neglect and the related psychopathology. 我相信今天他会给我们一个又深入又宽广的角度去看儿童时期的虐待跟忽略在相关的精神病上面的表现。Let's welcome Dr. Hanson.
Good morning, everybody. We've had such an auspicious beginning, such a strong beginning. I thought it was already afternoon. So first I want to echo what Dr. Hovind said. I thank you very much. I thank the organizers and the people who put this together. I really appreciate that they are doing this work, but I most appreciate also that they've invited me to share my ideas with you. I really, really appreciate it. So I wanted to thank you. So I met Dr. Hovind a number of years ago. When I met Dr. Hovind, I was primarily a clinical psychiatrist. I was a person working in the clinic. I was a clinical psychiatrist. And Dr. Hovind met me, and she said, "No, you also have to do epidemiology." So she pushed me encouraged me to also do epidemiology. So now I spend some of my time doing clinical psychiatry and some of my time doing epidemiology research with Dr. Hovind. So the talk that I'm going to give is a combination of those two things. I'm going to talk about the clinical work, about what's the clinical thing, and how that connects to the epidemiology. Because if we don't understand the clinical implications and what it's like in the clinic, it's hard to understand the epidemiology, which is about everybody. So it's important to have both of those perspectives: the perspective of the group, of the public health group, and also the perspective of the individual. So I'll spend a little time on the individual. Can I ask, how many people here are clinicians, do clinical work, or? Oh, so there's a good number of people. There's a good number of people who do clinical work. Very good. Okay, that's always a good beginning, right? That's good luck, right? Okay. So the outline of the talk is I'm going to do it's a long outline, but I'm going to do a clinical presentation. And then this is all a lot of detail, but it's about, after we talk about the clinical presentation, we'll talk about how that clinical presentation illustrates how child abuse could affect psychopathology, and then we'll talk about some solutions. So let's start with a clinical presentation, and we're going to call this case David. The person's name is not David, obviously, but we're going to call him David. David is a 25-year-old Orthodox Jewish man. He had gone through a regular Jewish Orthodox education, which is very conservative, and he married in his early 20s. Soon after marriage, he had a son. However, his wife found him to be very anxious, very unsettled. He was upset all the time. He couldn't relax, and he was very irritable, very short-tempered. He was unable to be cheerful. But he never hurt her and never hurt their child. He was actually quite kind to both of them. Despite this, she found him emotionally unstable, and she asked for a divorce because of all these sad, anxious feelings he had. She also took custody of their 2-year-old child. David visited the boy weekly after the divorce, and he took work on as an ambulance driver. However, as time passed, he shared with his brother how he felt, that he felt like a complete loser. He had no wife, which in that community, everybody was married, so it was very unusual, and he felt very odd because of that. He also didn't like his job. He didn't feel it was the right job for him. And he felt nobody cared about him, and nobody would mind or miss him if he died. He felt that he deserved all the sadness and the pain that he had because he was a terrible person. But he couldn't say why he thought he was a terrible person. He just had that feeling. He wasn't even sure later on whether he believed in God. And in his community, very strict, everybody believed in God, so that was very strange and made him feel bad too. He told his brother that he wanted to die, but his brother did not take this seriously. So he quietly started to planning how to kill himself. It was very important to him, because David was a good man, it was very important to him that if he kills himself, if he does this, that nobody else gets hurt. So he started practicing to drive to the bridge and to stop his car at the middle of the bridge in a way that would not hurt anybody else. One night, the feeling that he wanted to die became very strong. And I will quote him. He said, "It was like birth pains. It came in waves, stronger and stronger waves, the urge that I should end my life." So he drove on the bridge, and he left his lights on to make it look like he was changing the tire, so people would go around him and nobody else would get hurt. He went to the edge, he grabbed onto the pole, he pulled himself over the pole, and he jumped off the bridge. He remembers that as he was falling down, he could see a man in the river, in the New York City River, on a jet ski. You know what a jet ski is? It's a man on a jet ski. And the man on the jet ski saw him fall as well. And he watched him as he fell down. Later, much later, David learned that that man pulled his limp body out of the water. He pulled him immediately out of the water. It was a miracle because he was alive. Most people who jump off New York City bridges do not survive, even if they're found right away. He had multiple, for the physicians here, I'm going to go through some of the details. He had multiple spinal fractures. He had some spinal cord injury, bilateral pneumothorax, his lungs were damaged, broken ribs, he had internal bleeding, he had respiratory difficulties, he needed a tracheostomy, right? He needed a tracheostomy because he could not breathe otherwise. He had stomach problems requiring a laparoscopic surgery. He underwent months of different kinds of surgery and rehabilitation. In the hospital, he was also visited by psychiatrists. He told the psychiatrist, "I wish I had died in the water." He didn't want to face his life. It was even worse now. He was worried that the community would say that he was crazy. He was afraid he would be no longer allowed to visit his son, that the authorities would stop him from visiting his son. And his life would be altogether worse than it was before. He felt he had to cover up and hide the fact that he made an attempt. He started talking about the attempt as an accident. He said it was an accident, but he knew it was not an accident. Over time in the hospital, he recovered physically and he started getting better psychologically. He stopped being suicidal, but was still very unhappy. and he moved back from the hospital to his parents' house. And the hospital said, because you made a suicide attempt, you have to go into intense therapy, which is not that common in his culture. So he went to therapy twice weekly. After a few months of this therapy, he got very comfortable with the therapist. He learned to trust that therapist he was talking to twice a week. And he told the therapist, for the first time, telling anybody, that he was sexually abused when he was a child. That there was a man who was his uncle, and also a teacher in his school, and that this man had sexually abused him, starting at the age of 9. Once he told the therapist this, all the memories of this came back, and it started to be more painful. Once he started to remember, he started having more panic attacks and flashbacks and problems like that. But he suddenly realized that his suicide attempt was actually due to this abuse. That suicide attempt, which was 10 or 15 years later, was actually due to this abuse. And that he realized that the terrible feelings about himself for all of those years were because of this abuse. He realized that he always felt like he was the bad person because he was abused. He was dirty. He was tainted. He was broken. He said to me, "My brain feels like a jail cell, and I'm trapped in my brain memories." His mood became depressed, and his mind was racing. He started to have more panic attacks. And he said, "I now realize that I don't trust my parents. I don't trust anybody. I have never trusted anybody." He started feeling that he had no hope again, and he started feeling guilty about all his failures. His divorce, his bad work. And he concluded that he was a loser. His therapist encouraged him to talk about it some more, but it was too difficult. He was too afraid, and he stopped going to therapy. The therapist was afraid that if he discussed this with his parents, that they wouldn't understand, that the parents would not be supportive of him and not like this. That the parents did not know how to deal with this. This was their uncle, right? So the parents would be trapped and they wouldn't know how to deal with it. So the therapist was very worried and didn't want to talk with his parents. It was too emotionally complicated for them. It became clear that even though it was a good thing that David had finally talked about his abuse, it was coming too fast. All the memories were coming too fast. This was too hard for him. So everyone decided together that David should go back to the hospital, but not for physical health, but go to the hospital for psychiatric health. And he came to the psychiatric floor, and he was given some psychiatric medications, olanzapine, sertraline, and clonazepam, for those of you who care about the details. And I began visiting him in the hospital. He told me for the first time in his life he was beginning to feel that he was the victim of somebody else's bad actions, not the other way. That he was the victim, not he was the bad person. And he realized that the anger he had directed against himself in his suicide attempt was really anger that he had against the man who abused him. That anger belonged somewhere else, but he was putting it on himself. And that he had walked around with self-hatred for a decade. Everybody understands the concept of self-hatred, yes? He had self-hatred all this time, and that's why it drove him to the suicide. He also realized that he carried mistrust not only of his uncle, but of his parents and of everybody. He said, "I remain confused. I just feel like my head is spinning. It's so confusing to put together all the contradictions and all the lies, all the hiding and all the secrets. However, I think I will figure it out, and I no longer wish to die. I will figure it out, and I no longer wish to die." So see what we can draw, what lessons we can draw from this case. What are the elements? What do we see in this conversation and in his case? What are the elements? We see shame, confusion, and self-blame. Are those words all clear to everybody? I mean, stop me, ask me if you don't understand. We see secrecy, dark secrecy, right? Breaking the bonds of trust. You break the bonds of trust with your parents because you have a secret from them. Inner conflict. Am I good? Am I bad? Distrust of adults. Fear always of being hurt. Will the next grown-up hurt me? Fear of being revealed. Fear of his secret coming out. It was so shameful if his secret comes out. Emotional difficulties. He was depressed and anxious. That led to relation difficulties. Remember what happened to his marriage? What happened to his marriage? It didn't work. He was too damaged. Self-esteem difficulties, self-hatred. What will that lead to? What will that lead to? Self-esteem difficulties and self-hatred. That will lead to suicidal thoughts, right? I hate myself, I wish to die. This is what happened. So these are the revealed themes, right? This one case, I bring up this one case because the epidemiology is very important, but the individual case is also important. And the individual case speaks to us, I think speaks to our heart sometimes. It's important to have statistics and also to have the story, the narrative, speaking to our heart. So, what is childhood abuse? It's far more destructive than trauma. That's one of my big things because I started out interested in this because I was involved in trauma, as the wonderful introduction said that I was involved in trauma related to 911, as Dr. Hoven is, and continue to work with Dr. Hoven on 911 trauma. But most of the 911 trauma is something that happens to adults. It's very, very different when you're traumatized as a child. Because childhood abuse disrupts developmental process, right? It disrupts the developmental process. So we can understand this best in 3 steps. Number 1, the nurturing required for normal development. Number 2 is the effects of childhood abuse, psychological effects and neurobiological effects. And number 3 is the child's defenses, what the child's counter moves are. Because when you are abused, you make counter moves to defend yourself. But some of those counter moves are not healthy, right? Just like when you get a virus and you're coughing and sneezing and all the rest of that, it's somewhat helpful, but it's, you know, the counter moves that your mind and your body put together can sometimes be very, very negative. What are the nurturing requirements? This is simple. We know a child needs physical safety, shelter, food, hygiene, clothing, right? The child needs all of these things to grow up well. What are the emotional needs? A sense of being loved. You have to tell the child that he's loved. Being emotionally understood. Was this child emotionally understood? No, because he had all the emotions inside. He couldn't share them, so no one understood him why he was walking around upset all the time. You need a situation that promotes self-esteem, where as a child grows up, the child feels good about themselves. You need food for the mind. The child needs to have an education and constructive activity, something positive to do with their mind. And you need food for the soul. You need play and opportunities to socialize with friends, and the ability to develop a positive self-esteem may, in fact, be the most important. What happens when you have child abuse? It's the opposite of nurture. That's my whole message, okay? Child abuse is the opposite of nurture. There's physical trauma, but much more. Betrayal of the role that makes development possible, right? If the person that is abusing you is supposed to be the person taking care of you, they can't be a nurturing, right? They can't nurture. You can't get nurture from that person. If you're thirsty and you drink poison, that does not quench your thirst. A negation of trust. Having trust as a child is one of the most important things because we can't have a civilization, we can't have a society without trust. You have to have basic trust in other people. If you think everybody is going to hurt you, we can't have a society. There's a projection of guilt onto the innocent. There's an interesting inversion of truth. Does everyone understand what I mean, inversion of truth? In other words, the truth becomes false, the false becomes truth, lies become truth. You have to live with that. As he said, his head was always spinning, right? Because he couldn't tell the difference between truth and falsehood. And there's a creation of a prison of silence, which is what he said. Yes, I have a prison of silence. And there's confusion about body sexuality in the place in the world. So there's two different aspects. One is interfering with the normal process of healthy development, and you bring in toxic emotional pathogens, right? So it's two different things. One is you stop normal growth, and you bring in toxins. Yes? It would be like I sprayed weed killer on these flowers, right? So what are the counter reactions? The reactions that are adaptive in some situations can be very not adaptive in other situations. So what do? I learn to be distrustful of parents. That's a way to defend myself. I use anger as a counter to feelings of guilt, so I become angry with everybody. I become antisocial. I say I'm the bad one. Some people say I'm the bad one, let me be the bad one. Fine, I'll be the bad one. There's a position of fearfulness and a stance of being on the offensive. There's an internal demon of darkness, a sense again as you're a bad person on the inside. The world is not as it seems. So these children walk around and they say the world is false. The world cannot be understood or mastered. Right? Does everyone understand this? There's a sense you cannot master the world. It's too confusing, it's too difficult. All right, what are the effects of that was too dramatic for the slides. What's the effect on, so let me talk about effects now. We're going to talk about effects on psychopathology. I don't want to start with the most serious thing, which I think somebody brought up a question. Effects of childhood abuse on suicide attempt. There was a French-Canadian study of 1,684 people who were followed prospectively. Dr. Hovind talked so beautifully about the fact that we have to get the right kinds of data. We have to do these things prospective, ask the right kind of questions, and then follow people, right? So this was one study that did that. And they found that there was a hierarchy to the connection of abuse and suicide attempt. So the non-abused group of these people followed had 6% attempt among these people, followed over many years. Physical abuse, 11%, sexual abuse, 14%, and combined was 32% had suicide attempts. What about suicidal ideation? So that's more frequent with everybody. Non-abused group, 25% of normal people have suicidal thoughts at some point. For the physical abuse, it was 36. For sexual abuse, it was half of it. Half of the people, half of the kids who had sexual abuse had suicidal thoughts. And those who had combined abuse and sexual abuse had much more than that. So what do we know? To summarize, repeated sexual abuse had a stronger association than a single-time abuse. And compared to no abuse, the relative rates of suicide attempt increased. Somebody asked this question, so here's the answer to it. The relative rates of suicide attempt increased with the relatedness. Who was it who asked? I forget, they still here. The relatedness between the child and the abuser. So if abused by a non-related person, the relative risk was 2.3 over the non-abused people. If you were abused by someone in the extended family, it's 3.4. If you're abused by somebody in the immediate family, 5 times the risk. 5 times the risk of having a suicidal attempt. So the key is that relatedness does make a difference. Now, how about psychopathology? Well, in order to talk about psychopathology, because our ideas of psychopathology have changed so much over the last 100 years. So I just want to start with one fast slide on history. Because, of course, Freud in 1904 and 1905, Freud started talking about how abuse was responsible for adult psychopathology. But his theory was was changed. He himself changed his theory many, many times. And it got a lot of pushback. And there was pushback means, opposition. People were opposed to it. And for 2 reasons. The society in general didn't like it because, as Dr. Hovind really taught us this morning, the society is in denial of sexual abuse, right? So when Freud started saying, oh, they're sexual abusers, that's why we have psychopathology, people didn't like that, right? They said, no, there is no, not in Austria, not here. And from the medical scientists, they could not accept Freud's idea that memories could be pathogens. You remember, this is the idea that we take for granted now. But back in 1905, the idea that a memory, right, something that happened to you in childhood, could cause you psychopathology now was not yet accepted. So, Freud did start with that, but that was the beginning. But what do we know today in our more modern ideas? So here are the things. The maltreatment at elevated risk of the following externalizing. Now, I'm going to start with children, and then we're going to do adults. In other words, diseases of childhood and then diseases of adults. For the childhood, I think you probably know this already. Attention deficit disorder is elevated, conduct disorder, oppositional, defiant, delinquency, antisocial, and substance abuse. And here are all the the references to those findings. Victims of maltreatment also risk for INTI, major depressive disorder, anxiety disorder, and post-traumatic disorder. And they're at elevated risk for the rest of their lives of getting post-traumatic stress disorder if they have a trauma. So if you were abused as a child and you have a trauma, you're much more likely to get PTSD, right? Not everybody gets PTSD from a trauma, but if you're abused, you're much more likely. What about adults? I'm going to run through this quickly because we're going to talk about this and people are going to talk about it more in the afternoon, but I want to run through just a quick list. Mental health disturbances, panic, depression, anxiety, hallucinations, even hallucinations, physical disturbances, sleep disturbance. I'll show you a statistic in a minute. Severe obesity comes from abuse as a child, multiple somatic symptoms. Substance abuse is a little controversial. There are some studies that find that substance abuse is definitely elevated, other studies have more doubts about it. So that's still something we don't know enough about. Impaired memory of childhood. People who have been abused have difficulty with the memory of childhood. The number of different age periods affected depends on how severe the trauma was. But especially when there is abuse in the family, kids have a lot of difficulty remembering their childhood. And they have a lot of difficulty with their own sexuality. Some of them end up having earlier intercourse, right? Kids who are abused act out, right? They act out and they have earlier intercourse, they become promiscuous. Other people are sexually uncomfortable and have difficulties having sex at all, in normal sex. They have difficulties with that. Also, there's high levels in adults of perceived stress. Remember David, he was always walking around stressed. His wife couldn't stand being around him. And there's also, which was not in our case, but there's a risk of perpetrating intimate partner violence, right? So you're more likely to yourself to be an abuser, okay? Now, let's talk about adult psychopathology, and I'm going to break up adult psychopathology into sexual abuse and non-sexual abuse, two sections. So let's start with non-sexual abuse. So for non-sexual abuse in childhood, a meta-analysis of 124 studies was conducted by Norman. And here's what he found. He found that for depressive disorders, physical abuse gave you an odds ratio of 1.5, 1.5 times more likely. Look at this. Emotional abuse was 3 times more likely. And then neglect. Remember, we're not talking about sexual abuse now. That'll come later. Neglect was 2 times. Same thing. He found drug abuse 2 times. For physical abuse, 1.4 times for emotional. Neglect is 1.3 times. Suicide attempts, for physical abuse, it was 3 times, 3.4. Emotional abuse was 3.7. And for neglect, it was 1.95. Sexually transmitted infection and risky sexual behaviors also show this pattern, right? It increases across physical, emotional, and neglect. So, what can we conclude about non-sexual abuse and adult psychopathology? There is a causal relationship between non-sexual abuse and mental disorders later on, and all forms of maltreatment should be considered important risk factors. And the awareness of the serious long-term consequences should encourage better identification, as we're going to talk about later. Now, what about sexual psychopathology? Well, what about psychopathology after sexual abuse? So, Chen performed a meta-analysis of 37 studies with a total of over 3 million participants in these 37 studies. And he found that if you had sexual abuse as a child, you had 3 times more likelihood of having an anxiety disorder, 2.6 times more of depression, 2.7 times of eating disorder, 2.3 times PTSD. Look at this. Sleeping disorders. 16-fold. Why? Does anybody have any idea why sleeping disorder? Is a bed a comfortable place if you've been sexually abused? A bed is not a comfortable place. A bed is not a safe place. And that might be one of the factors that shows that people have terrible sleeping disorders. And we know, Dr. Hogan is doing work on this right now with that sample we talked about, that sleep disorders can mess up everything else, right? You have bad sleep, you have bad psychopathology. So what's the conclusions from this? Okay, there was no association in this study between sexual abuse and schizophrenia, but some people have found a relationship Not the whole schizophrenia, but between hallucinations. So some people do get hallucinations as a result, but not the full-blown schizophrenia. Same thing with bipolar. This particular study did not find any relationship to bipolar. And also it's important to notice that the connection between sexual abuse and later psychopathology was made much worse by a history of rape. So if there's sexual abuse, if there was rape that happened afterwards, if that made things much, much worse. Just like with the PTSD, people are sensitized and they can't overcome that next trauma. All right. What do we know about developmental neurobiology and child abuse? This is an entire field, and I am not going to pretend to give you a neurobiology lecture right now. I think it's just important that we understand that the functional capacity of the human brain, as we ordinarily use the human brain, the adult brain, requires an extraordinary set of steps that the brain goes through developmental steps. We don't only go through emotional development, the brain goes through specific steps. Abuse of any kind can interfere with the steps that that brain is going through, the connections that the brain is building, right? The elegant sequence is vulnerable to extreme repetitive or abnormal patterns of stress. So patterns of stress when you're a child can completely change brain development, right? So converging evidence from neurobiology and epidemiology, when you put them together, it suggests that early life stress is related to it and causes enduring brain dysfunction. So you have a different kind of brain. We think of it psychologically mostly. As a psychiatrist, I was raised mostly psychologically. You think of, oh, the child has no trust, they have these difficulties, but they have brain changes. And again, we're not going to go into the whole biology today because that's an entire different lecture about the biology of abuse. We're not going to talk about it. I wanted to give you one important other indicator, though, of the biology. A history of physical abuse during childhood can be detected in glucocorticoid receptor gene. So this is epigenetics, right? What happens if you're abused as a child? The epigenetics of your glucocorticoid receptor gene. What does the glucocorticoid receptor gene take care of? What does that help you with? What's the function of that? That is stress. The glucocorticoid system is what helps you deal with stress. But there is a change, right? An epigenetic change in that entire stress system if you were abused as a child. And that's going to obviously affect it. All right, what about the DSM system? So I think you probably use the ICD here more than the DSM, right? Do people use the DSM? They use both? So the DSM system, when the DSM came in, DSM-3, it said, we are atheoretic, right? Atheoretic means we have no theory about how psychopathology starts, right? We don't know the theory. We're just going to describe it. We have no theories. We're going to reject all Freud's ideas about what causes psychopathology, all the old ideas. We're just going to describe it because we don't know enough. There was one exception to that, and that was for post-traumatic stress disorder. For post-traumatic stress disorder, the DSM said, yes, we know what the source of that is, right? It's a trauma. Trauma causes PTSD, so that was one exception. Now, in the new DSM, the DSM-5, the new chapter, has separated out trauma-related disorders from other anxiety disorders. And in that chapter, very interesting, they not only talk about fear-related disorders. PTSD causes fear-related disorders, but they also talk about attachment disorders. They recognize that abuse can also cause problems with attachment. So there's fear and there's attachment. Keep that in mind for a later slide. So what about a post-DSM? Right now we're supposedly in the post-DSM world. There's a lot of conflict. People say, well, diagnosis is too simple a system. We need a more complicated system, a more dimensional system in order to understand psychopathology. Well, in this system, you can see that maltreatment acts affecting a number of basic cognitive, emotional, and behavioral systems, which fit into the RDoC system and to some other post-DSM systems. And let's look at what these are and talk about them for a minute. Because remember I told you that the problem with child abuse was that it interfered with the nurturing that you needed in order to have a normal development. So let's talk about what specific things get interfered and get, as we say in America, messed up. Number one, fear learning system. right? You become fearful. You have an increased threat sensitivity and you become fearful. You're afraid of things. You're afraid of people. Number two, it turns out that your reward and motivation system, you have less responsivity to reward. You don't expect something good is going to happen. Your basic reward system, and our reward system is so important because that's what motivates us, right? Remember, David didn't have very much motivation. He had no drive, right? He couldn't anticipate good things happening in his life. So that is the reward system. The emotional system is messed up, and those of you who have treated people who had child abuse, you will recognize this because it's very noticeable. They have difficulty with their own emotions, and they have difficulty recognizing other people's emotions. They have difficulty recognizing other people's emotions as well. And when you can't recognize other people's emotions, you can't recognize your own emotions, are you going to have a wonderful marriage? I don't think so. You're not going to have a wonderful marriage. And that's what happened with David. David couldn't recognize his own emotions or his wife's emotions, and she couldn't take it. And finally, we talked about this, the attachment and trust systems, right? There's a deficit in attachment and trust. If somebody who is supposed to be taking care of you violates that trust and hurts you and takes advantage of you for their own selfish reason, why should you trust them? You would have to be crazy to trust them, right? So you don't trust. And if you don't trust, it's very hard to live a normal life without trust. Okay. Very briefly, let's talk about what are some treatment approaches. It's very important to say that mental health problems are not inevitable consequences of being maltreated. In other words, there are ways that we can change this trajectory. We can change this story. Access to socially supportive relationships can buffer. See, David didn't have access to socially supportive relationships because he was too scared to break the silence, right? So if the kids can tell the story and tell their parents, then their parents can be supportive, right? But if they don't even know there's a problem, then you can't be supportive. So that can be one of the problems. But we have to identify these kids early and make sure that they have a socially supportive system. And that's within the family. What about evidence-based treatments? Well, there are parental interventions. There's parent-child interaction. I'm just going to name them because obviously can't cover all this in this thing. There's parent-child interaction therapy, and there's abuse-focused cognitive behavioral therapy for the parents. For the children, there's trauma-focused cognitive behavioral therapy, there's trauma-focused CBT, there's child-parent psychotherapy, and there's something called complex trauma treatment, And the complex trauma treatment recognizes, like in the case of David, you can't have somebody just come and spill out everything that happened to them, right? It can overwhelm them. So the old therapy thing was, well, tell people to talk about their trauma. If they talk about their trauma, they're good. But we found out if it's child abuse trauma, you have to prepare them first. Remember, so David wasn't prepared for all the effects of revealing this. So this is what the STEP system is, which it says you first teach people dialectic behavior therapy, which is emotion regulation. Then you teach them mindfulness. Only after they have these tools and they're stronger about dealing with their emotions, then you can do the exposure. Then you can let them talk about the trauma. But first, you have to strengthen, right, their emotional abilities. Interventions for children in the out-of-the-home care. This also came up, the notion that a lot of these kids are going to be in institutionalized care. And you just read it in your slides. There's a number of different, these are all evidence-based systems that have been developed to help in the outside of the home thing. What about a public health approach? Well, this is where Dr. Hovind changed my approach to clinical care. I would go into the hospital and treat one patient at a time. And that was good, and I still do it, and it's very important. But Lee, Lee did a meta-analysis, and he estimated that 59% of all adult depression and anxiety is due to sexual abuse. Now, I'm not positive that Lee is right, but he did a pretty thorough study, right? And even if it's half that, it's still amazing, right? He said 60% of depression is due to childhood, right? And he estimated, they built a model, and they estimated that if you reduce child abuse by 10%, so people don't think we have to eliminate it to do any good. If you reduce it by 10%, he said you'd prevent 31 million cases of depression and anxiety. Now, I work pretty hard, but I can't treat 31 million patients, right? I don't know how, I do not have the time to treat 31 million patients. right? That's why I work with Dr. Hogan. I'm trying to prevent them from getting the disorder in the first place. Much more efficient, right? It is much more efficient if I can reduce child abuse by 10%, I can get rid of 31 million cases of depression. So, what can we do? Primary prevention, obviously, which is, and that goes at different levels. Universal education about childhood trauma and its effects. There should be public relations. We should be talking about this, right? There are, I see around Taiwan, every place you go, it shows you how to use the soap, right? The hand soap. How do you properly use your hand soap, right? There are signs, how to properly use your hand soap. There are signs in the taxi about wearing a seatbelt, right? We have public health signs everywhere, right? Public education about prevention of different kinds of things. So we need a universal education. We need to talk to everybody. It needs to be a big public event. We need better public health programs in parenting skills, right? We need to offer parenting skills. When we have good prenatal care, and I understand here in Taiwan you have good prenatal care for the mothers, we need to expand that prenatal care to talk to the mother about, are you ready to be a mom? And you probably are, as Dr. Hogan will tell you, but bring the dad in, he certainly isn't. So talk to people, right? Part of prenatal care ought to be, right, that we talk to parents, we make sure they understand this, we see if they are going to have too much stress to be able to deal with the child without themselves, right, falling into that danger of being abusive. And early recognition of families, which is, I think, what a lot of you people in the hospitals do, right, is you identify this and you detect this, and that's what we call God's work, right? That is God's work of early detection in the hospital. And how do we do this detection against educating? We have to educate primary caregivers, and that's why I want to thank the organizers of this conference, because they are doing exactly this line, educating primary caregivers to recognize trauma and do better at it. We need peer education. That is among, and this is a work that Dr. Hogan has done in the Saley Project, where we teach high school kids how to recognize mental health in themselves and their friends, how to talk about emotions with themselves and their friends, right? So that all high school kids can become support systems for each other. We need to lower the stigma. This is a really paradoxical and difficult thing, to lower the stigma. And Dr. Hogan talked about this. I thought she talked so wonderfully about how her team tries to help the family rather than punish the family. Do you all remember that interesting point she made? You find out the family is in trouble, so don't get the family in more trouble, but try to see if you can help them. Because this is so hard, right? On the one hand, we want to stigmatize child abuse, right? We want to say, it's a terrible thing. If you do it, you're a terrible person. Of course we want to do that. But at the same time, if we do that, we drive it underground, right? So we need something much more sophisticated. Some sophisticated way, right? Because we want it stigmatized in the sense that we want people not to do it. But we don't want it stigmatized in the sense that people run away from admitting it, run away from discussing it, So it should be possible for a parent to come in and say, look, I'm so sorry, I lost control, I need help, right? I need parenting help. Right now, if they do that, a lot of them end up in jail, I think. We need increased practical access to care, so this is true for everything. We need more help for the families. Family therapy, parent rehabilitation, destigmatization, I've actually mentioned these, and increased protective factors that put normal development back online. So programs that promote peer interaction, we need to have more peer interaction. I'm a little bit worried about the kids spending all this time on the screens instead of playing with each other, right? So is that going to help? We need to do more work in which the kids have resources, even if they're having problems at home, they have other resources for social support. Okay, so up until now, I've been talking about, because this is what the conference is about, we've been talking about child abuse, that is, a child being abused. But I just want to take one or two slides before I finish to talk about that there is a larger, different thing which it encompasses, and that is kids who are experiencing negative events and traumas, whether it's from the family or not from the family. And that's called ACEs, adverse child experiences. Adverse being bad, negative child experiences, whether it's childhood or not. So these are a broad spectrum of adverse events. Maltreatment could be neglect, separation, but also traumas, terrorism, lots of things. It's a major public health problem. It occurs at a high rate, and higher rates with bad weather problems. It's happening more and more. And ACEs have also, just like child abuse, they've been linked to bad health outcomes. So here are all the types of ACEs that you could have. And here are some of the statistics on what happens if you have any kind of ACEs, whether it's child abuse or not. And again, I'm not going to go through everything, but your 1.6-fold increase of being obese, higher thing of sexually transmitted disease, smoking, depressed, increasing or attempting suicide, having an alcohol use problem. All of these kinds of things happen with these adverse things. So Dr. Hovind and I and Dr. Tiano just finished a book about ACEs. This is not so much about childhood, but this is about negative things that happen to children. It's international. We have contributors from all over. And this book discusses what happened to kids in disasters and how many, many heroic people who contributed to the book talk about how they took care of their kids during that thing, whether it was in Fukushima or whether it was in New York or whether it was in how those kids survived those negative events. There are lessons to learn from that into how we help kids who have been abused as well. And I'm plugging the book. So thank you very much. I hope I didn't go over too long, but I hope that's a bit of an overview of a very, very difficult field. And I congratulate you for taking this on and for making it your goal to reduce both child abuse and the effects of child abuse here in Taiwan. I congratulate you for your efforts.